I'll just do a quick introduction. Welcome everybody. Thank you for joining us. This is the NOAHE rounds 4. I guess that means it's the 4th year we've been doing these, and this is the eighth session this year. Glad to have you with us. Please do join me in welcoming Dr. Chris Sampson, our presenter today. Chris relatively recently finished his PhD at the University of Nottingham in the UK, and he's now working as a principal economist at the Office of Health Economics in London, and is going to talk to us today about an evaluation and assessment of Sleepio, a digital health technology, which I'm going to guess is related to sleep in some fashion. Particular interest to us as we ramp up our work here at IHE in digital, and I think important across the health of evaluation and research landscape at the moment. So we look forward to hearing about that. Before we begin, I've just got a couple of housekeeping items to mention. Participants throughout will be muted, so if you do have questions, please put them in the question. Please use the question box or the question functionality in the GoToWebinar interface. I'm told there's a question mark icon that you can click. It's not a help button, but rather it's for asking questions. We will hold all the questions to the end, so please feel free to ask throughout, but we'll hold them to the end. But if you have an idea for a question, put it in the chat box and it'll be there for the end. So thanks. So with that said, I will turn over now to Chris. So Chris, go ahead.
Lovely. Thank you, Jeff. And hello, invisible attendees. Thanks for coming to listen to me talk about this project. So this is describing some work on, Jeff was right, it's an app, a program relating to sleep and seeking to address sleep problems. And there's a few parts to it, so I'll talk through the different parts of the study, and then I think there are some interesting generalizable challenges and topics for conversation that go beyond the specifics of the findings of our study. So this work, the work that we've been doing on Sleepio has been going on for about 3 years. Some of the months in those years were quite inactive, but we've been working on it for quite a while, and it's technically covered 3 different projects from 2 funders. So we're getting to the point now where we're able to bring together a few different strands of work. So yeah, a few notices there. I believe this is going to end up on YouTube, so I guess you wouldn't be doing any screen grabs anyway, but I'm happy to share these slides, and yes, I will leave plenty of time for discussion at the end, so please send your questions in. I'll first go over a bit of background, particularly what is Sleepio and what's the kind of background to the research and the decision problems relating to the use of Sleepio. I'll describe the main body of work that we did, which was a real-world evaluation. This was in some senses kind of a straightforward empirical study, so I'll describe that in the way you would expect. I'll just outline what we were seeking to achieve and how we did it and what we found. And then I'll quite briefly, though it's something that we might want to discuss in general terms in a bit more detail, is the NICE assessment process in relation to Sleepio. So I'll kind of highlight the work that we've done on that. Although unfortunately some of it I'm not yet able to share. I had hoped that we'd be in a position today where NICE had shared more information particularly about the committee stage, but some of that's still secret. But nevertheless, there'll be plenty that we can talk about. So as I said, I think there were quite a few interesting points that came out of this study, and there's lots of different topics that it touches on and challenges for applied cost effectiveness analysis and health economists, and yeah, here are some of them. I think I'll return to this slide at the end, because it might be good food for thought for discussion. But essentially, the methods that we have employed and the type of technology and the type of comparator that we were looking at is not necessarily the usual fare of economic evaluation, and it kind of highlighted some challenges in the assessment process, and some kind of potentially novel approaches that could support the evaluation of digital health technologies in the future. One of the things I've got there is highlighting that we were looking at like a population rollout. Obviously, I'll describe this in a bit more detail later, but this kind of public health angle added an extra complication to it. And yeah, it was not clear that the appraisal processes that are in place for a technology like Sleepio, at least in the UK, it's not clear that they're appropriate, and they could probably be improved in some ways. And so I think that's something that we could potentially talk about. Before I get started, I'll also highlight that you'll see that there aren't any citations in this presentation. That's not because we've created something entirely novel, but because they're kind of better organized elsewhere. So we published a preprint recently describing our real-world analysis. So all of the kind of background to the methods and things, and all the relevant citations for that are included there. So these are linked in the slides, but maybe we could do that YouTube thing where I say click the link below. Maybe we could do that. And also there's information on the NICE website. As I said, I had hoped that a bit more would be available today, but it will be available in the near future. So this is kind of ongoing. But a lot of the background, particularly to the clinical evidence for Sleepio, is accessible through the NICE website, as well as some of the background to the economic evidence. So a bit of background to our research. So the most important question at this point is what is Sleepio? So Sleepio is a digital health technology. It's a program, you might call it an app. So the company that developed Sleepio and commercializes Sleepio is called Big Health. So Big Health are currently in the process of developing an Android app. They already have an iOS app, but in practice, most of the engagement that a patient would have with Sleepio is actually in a browser, so on a computer. But still, people like to call it an app because that's cool. Sleepio delivers cognitive behavioral therapy for insomnia. Obviously, it's digital cognitive behavioral therapy for insomnia, so we call it DCBTI. There are other DCBTI options out there, but Sleepio is kind of the most researched one and the kind of most commercialized one at the moment. But there is some other research on DCBTI. Sleepio delivers 6 20-minute CBT sessions over at least 6 weeks. Patients have to have at least a week passes before they can access the next session. So it's at least 6 weeks per course. And during this time, patients complete a sleep diary. This is something that can be done manually, or it can the app can get data from your Fitbit automatically. So there's some kind of automation there that you wouldn't get with regular CBT. And this information is used to tailor the advice that a person receives through the Sleepio app. You can see the little man on the phone there. Perhaps he's called the prof, and he personalizes the CBT that a person receives. Users are also part of a kind of wider Sleepio infrastructure, so they have access to a library of materials that they can use to support their sleep, and also access to a community of other Sleepio users. So there's plenty of research on sleep, and quite a lot of research already on Sleepio. So before we started on this work, there was quite a lot that we kind of already knew. So, I mean, there's quite a lot of research to suggest that sleep difficulties and insomnia specifically can have a big impact on people. There's some good evidence showing that poor sleep affects health-related quality of life and productivity, but kind of intuitively and in the evidence, we see that sleep kind of impacts everything in people's lives. It's also a risk factor, insomnia at least, is a risk factor for lots of other physical and mental health problems. In the UK, at least, and I understand it to be the case in lots of other countries, insomnia is quite poorly diagnosed and managed. Partly that's because insomnia is often comorbid with other conditions. So if somebody presents to a doctor with anxiety and they also happen to have sleep problems, then the doctor's likely to treat the anxiety, and the insomnia will be considered a symptom rather than a condition that needs treating in itself. And there's not much really at GPs, at least in the UK, there's not much at GPs' disposal for supporting people with insomnia or sleep problems. So NICE guidance recommends that people are offered CBT, so face-to-face CBT, but there just isn't the capacity to provide that. So people tend to be treated with verbal advice from the GP or sleep hygiene education, which might be something as simple as a pamphlet which says things like don't drink coffee after 5 p.m, that kind of stuff. Or GPs often provide prescriptions for sleep promoting medications like hypnotics, and these are often used for kind of long periods of time when they shouldn't be, so it's not an ideal situation. Unusually for a digital health technology, there's quite a lot of clinical evidence supporting the use of Sleepio. So there's been at least 12 randomized controlled trials, and these tend to focus on condition-specific outcomes. There are other things looked at in some of these studies, such as productivity and things, but in general, we have quite a big body of clinical research demonstrating that Sleepio is effective in improving sleep. In terms of the kind of economic side of things, there's some evidence that DCBTI generally and Sleepio specifically may reduce prescriptions, and there's also some evidence from various populations that it might improve productivity. So these are the kind of things that we might want to take into account in economic evaluation. But in general, before our study, that we didn't know a great deal about kind of what we could call the economic evidence. There wasn't a great deal of information available regarding NHS, well, healthcare resource use. And more generally, there wasn't really much evidence from kind of real world populations. So there's good reason to think that a trial setting might not be the best setting in which to estimate the expected resource use impacts of offering Sleepio to a population. Which is why we went on to do a real world evaluation. So the funder had a few questions, and we had a few questions. So essentially, what is the resource use impact of Sleepio? That was kind of the starting point. And our work was set within a wider study, which was kind of an implementation study testing alternative ways of trying to roll out Sleepio. So yeah, the question around what if Sleepio was rolled out to the whole population was kind of core to our study design. Getting into the study, my question really was about whether Sleepio might be a substitute or a complement for other types of healthcare, and as a consequence, going into it was kind of ambiguous whether Sleepio would be cost increasing or cost saving. You know, it could be a substitute for something that's high cost or something that's low cost, or it may just be an add-on for other types of care and whether or not Sleepio is cost incurring or cost saving overall. It depends on this kind of relationship. So that's how I was thinking about it. But essentially our research question going into the study was what is the effect of Sleepio rollout on primary care costs in the NHS? And in primary care costs, we include GP contacts and prescriptions. So we didn't do any kind of randomization. Our study design is quasi-experimental. Essentially, we do a before and after study. So before and after rolling out Sleepio to the population. So in our study, essentially the control group is people before Sleepio was rolled out, people's use of healthcare before Sleepio was rolled out, and the intervention group is after Sleepio was rolled out. So for this purpose, we conducted an interrupted time series analysis, which is quite a robust and well-recognized method for this kind of study and this kind of research question, where essentially the time point represents the exposure to the intervention, the only exposure to the intervention that we observe. So we don't observe whether or not people use Sleepio or when they start using Sleepio. So for this to be a sound basis for trying to identify a kind of treatment effect cost, it relies on a couple of assumptions. We assume that people who don't use Sleepio aren't affected by Sleepio, and we also assume that people who are not included in our data set, because we don't include the whole population, as we'll see, people who are not included in our data set don't use Sleepio. We could talk about these assumptions, but they seem realistic. So our main source of data came from primary care, from GP practices, and as I said, we didn't include the whole population. We anticipated that the vast majority of people within the population wouldn't use Sleepio, so to include all of those people would just kind of add a lot of noise to the data. So we wanted to focus on people that we would expect to use Sleepio, or we would expect might use Sleepio. So these 4 bullet points here are inclusion criteria. So anybody with a diagnosis of insomnia or anxiety or depression, or who received some particular types of prescriptions, was at any point in our time frame, they were included in our data set. One of the inclusion criteria was also referral to Sleepio. So we managed to make arrangements such that when somebody presented to a GP with sleep problems, the GP would get a pop-up on their computer screen that asked them if they wanted to refer the patient to Sleepio. So that provided a means of identifying people who might have used Sleepio, but it's not a clean indicator of whether people actually did or not. Our data set was drawn from 9 GP practices in Buckinghamshire, which is a county in England. The whole study was across a region called the Thames Valley, which is three counties, but we focused on one county where the kind of implementation strategy that we wanted to evaluate was being used. We were aiming for recruiting 10,000 people who might use Sleepio. Why 10,000? I thought it seemed like a good number. The data system that we were extracting data from was called EMIS, which I guess some of you might have come across at some point. And our data set was constructed from resource use counts per patient per week. So each line of data was a person week, and within that line of data we had, for example, how many times they went to see their GP, how many tablets of drug X at dose Y they were prescribed. So it's quite a simple data set, but quite a big data set. We also had access to data collected through the Sleepio app. We weren't able to link this data to the primary care data, so we didn't make much use of the Sleepio app data, but it provided more. Well, it provided the only reliable indicator of uptake, because everybody who used Sleepio, their data was in Sleepio. But essentially, there was little scope for any additional data collection. We were just kind of making do with what we could get our hands on, and the primary care data were all anonymized. So yeah, it was quite straightforward in that sense. We didn't seek to collect lots of additional data. So the primary outcome for the analysis was average primary care costs per person per week. And as I say, these included GP contacts and prescriptions. We costed these things in the kind of standard unit costs way. The prescription data were quite good in that we observed like the number of tablets that someone was prescribed and at what dose. So we were able to get quite specific costs for that. I should say that we only included data on prescriptions that we thought were relevant, so hypnotics, anti-anxiety drugs, that kind of thing. And we conducted a segmented regression analysis. So this was a multi-level generalized linear model. I'm not going to go into much detail on this because it's not that interesting. But I'll briefly just say what the key coefficients in this model represent. So this is quite a standard segmented regression analysis model for an interrupted time series analysis. So time is literally just the week number in the data set. So as we'll see in a moment, we've got 117 weeks, so that's just a number for the week. Intervention is an indicator, binary indicator, for whether or not the time t is within the intervention period, the rollout period. So we set a rollout period of 6 weeks. This is based on the idea that not everybody has access to Sleepio from day one. It takes a little bit of time for the rollout to take place. And then post is the number of weeks after rollout. So based on these three coefficients, you can construct a trend before Sleepio rollout and after Sleepio rollout, and that's essentially what a segmented regression analysis does. And we tested a few different specifications, but I probably won't talk about those. We also did some secondary analyses. Some of these were pre-specified, like looking at the people with anxiety or depression, and some of them were just for kind of trying to explain our findings. But again, I'm not really going to talk about those today. So these are the this is a description of our data set, really. So we had 1.2 million person weeks, which sounds like loads, but all this is it's just 10,704 patients. That's how many patients were identified with our criteria from the 9 practices, which is about 8% of the GP practice patient lists. 10,704 patients over 117 weeks. So we have data from October 2017 to January 2020. The study started in October 2018. Sorry, Sleepio rollout was in October 2018. So we got a year retrospective data before rollout, and then we got a year and a bit after rollout. I'll talk about that a bit more in a moment. So in the GP referral data, we saw just over 1,000 people were referred to Sleepio, but the number of people actually using Sleepio was a bit higher. People could access Sleepio, didn't have to access Sleepio through their GP. They could access Sleepio just having seen a poster or heard about it on the radio, things like that. This graph here is in part really useful and in part quite unhelpful. It's useful because it demonstrates kind of what a segmented regression analysis is trying to do, trying to estimate the trend before and after Sleepio rollout. So these dots are just the average cost per person per week across the 117 weeks, and the green dots along the bottom are prescriptions. and the pink ones are GP contacts and the blue is the total. We can see that prescription costs are consistently quite low. A lot of the drugs that are used in this context are very cheap. But it's quite unhelpful in a way, this graph, because it artificially shows, it seems to suggest an increase in costs after Sleepio rollout. And this is something that was expected. This is something that was anticipated, and why we extended the follow-up period to more than 1 year. And it's because of these pumpkins. So the pumpkins represent October, November, and in the UK at least, I don't know if it's the same in other countries, but in the UK, October and November are the two most popular times for people to go and see their GP. More people go to see their GP in October and November than any other time of year. They're the two biggest months. So we'd anticipate a spike there. And likewise, we would anticipate a big drop off in December. So because we've got these two spike periods in our post rollout period, it kind of artificially looks like an increase. But yeah, as we'll see, we took that into account in our modeling, and this was something that we anticipated. But this is something that has made it quite difficult to communicate. So these are the regression results. The key ones are the ones there in bold. So I'll just briefly explain what they mean. A positive coefficient on time simply means that there's a slight upward trend. I say slight because it's a very small number. So that kind of fits with this pre-rollout trend that we see here. It's slightly increasing over time. Not a big surprise there. The intervention coefficient suggests, because it is negative, suggests that average cost per patient dropped during the rollout period of Sleepio, which contradicts this graph. But essentially, it suggests that the average costs in October and half of November, because Sleepio was rolled out at the start of October, it suggests that the costs were lower than we otherwise would have anticipated them to be. And the coefficient, the negative coefficient on post, describes the post rollout trend. So essentially what this shows is that Sleepio rollout negated the increasing trend that we saw before rollout. If you get down into the many decimal places, you see that it doesn't completely negate it, but essentially the effect of Sleepio rollout was that healthcare costs, primary care costs, stopped increasing. And yeah, so we've got these various specifications here. As you can see, the seasonal adjustment seems to be the crucial one. By the time we get to model 4, we see the effects disappearing, and that's when we stop including seasonal adjustment in the more parsimonious models. Model 5 is a basic OLS model. Yeah, so we see that that's important, but the other covariates were less important. So this table shows some projections in time, so beyond the 65-week follow-up, and some projections through different populations. This was to kind of provide some policy relevant numbers, but is obviously more speculative. The figures in bold are those that we actually observed, so that's the real bit, and the rest are projections of our trends that we generated using the segmented regression analysis. So across the kind of headline figure, I suppose, is that across the 9 practices over the full 65-week follow-up, we saw a reduction in costs of £71,000. So this worked out at £6.64 per person, which doesn't sound a lot, but we have to bear in mind that most of those people aren't using Sleepio, because we saw uptake of about 1% across the whole population. So if we were to just kind of divide that by the number of people that we observe to be using Sleepio. We don't observe it at the individual level, but just based on the numbers, we're looking at an average saving over 65 weeks of about £70 per Sleepio user. All right, so that's the bulk of our analysis, and unfortunately, I don't have a great deal to say about the NICE assessment process, but it could still be the most interesting thing for us to talk about in general terms. So here's a bit of insight into how long this has been going on, mostly for reasons out of NICE's control. But originally in November 2019, the heady days of late 2019, we and Big Health, who own Sleepio, set out on starting the process with NICE as part of their medical technology evaluation program. Just after we got started, NICE decided to pause the process for Sleepio, and this was because NICE were engaged in a digital health technology pilot. So essentially, NICE were reconsidering or thinking about how they might evaluate digital health technologies, and they paused the Sleepio appraisal to wait for the findings of that pilot. And then COVID happened and everything just paused for a lot longer. And then towards the end of 2020, we got started for real, and NICE published their scope, and we at OHE supported the submission in terms of the economic evidence, which relied quite heavily on the work that we did in the real world evaluation. And then last month, there was the first committee meeting, unusually, because it's not going exactly as anticipated. There's a second first committee meeting scheduled for June, and then ultimately we'll be hoping that NICE will have made a decision and published their recommendation by the start of next year. But the process has become quite complicated, and although I can't get into the specifics of it, it is, at least in part, because of the nature of our study and the difficulty of incorporating a real world analysis which isn't based on individual level treatment exposure and cost and outcome estimates. It's partly because of the difficulty in processing that. But yeah, so NICE published their scope, and it was much as we anticipated. There wasn't really anything specific with regard to costs. The key thing is that as part of the submission, it's necessary to demonstrate that Sleepio is cost saving. This may seem a bit counterintuitive, especially because there's quite a lot of evidence to suggest that Sleepio is not just non-inferior, it's effective, especially compared to current practice, which is often close to nothing. Yet despite that, it's still necessary to demonstrate that Sleepio is cost saving in the economic submission. So we developed cost consequence analysis using NICE's templates, and nominally the model is based on remission, but because of what I described from our study, looking at the whole population, we didn't distinguish between people who experienced remission and those who didn't. But the NICE's model template expects there to be some kind of stratification by treatment outcomes. So we essentially just treat the alternatives as equivalent. But overall, the model estimates a saving based on Sleepio's pricing and based on our expected uptake. It demonstrates a saving of £45 per patient. So we kind of ticked the cost savings box, but as I say, the process is not over yet. NICE's MTEP program, the Medical Technology Evaluation Program, has a kind of tiered system, which you can find out more about online. But it's not necessarily the case that a technology would have to demonstrate cost saving, but There isn't really any quali evidence for Sleepio at the moment, so that would make an alternative route a bit trickier. So that's where we are. As I say, I had hoped to be able to share with you the outcomes from the initial committee meeting with NICE, but unfortunately I'm not able to do that. Details will be online soon, I hope. And likewise, I can't really share the next steps, but we could still talk in general terms about the challenges of using real-world evidence to inform this kind of reimbursement decision making, and the specifics of digital health technologies, and maybe even Sleepio in particular. But essentially, conclusions are that based on our work, population rollout of Sleepio is likely to reduce primary care costs. We see GP contacts and prescriptions reduced. Prescriptions tend not to cost very much, but it's prescribing that it should be reduced for reasons other than cost. So there's also some kind of positive outcomes in that respect. I think our study is quite a good case study in how digital health technologies can be evaluated using routinely collected real-world data. So we relied on data that was already being collected routinely by GP practices, and we were able to use a bit of extra data from the Sleepio app. And I think this is quite a good demonstration of how these technologies can be evaluated, especially if they have a kind of population level rollout. The interrupted time series analysis approach seems like a good one, and there are a few examples of it in the literature, especially for digital technologies. And there's also the point around standard appraisal pathways not really being ready or designed for these types of technologies, and for this type of evidence. So several issues with Sleepio in this case, but the fact that it's a population level rollout, the fact that the comparator is not really effective care, there are several aspects that make current pathways challenging. So that is it from me. I'm just going to put on this slide that I showed earlier as a potential bit of food for thought for the discussion. But yeah, thank you very much for listening.
Thanks very much, Chris. We've got a couple of questions in the question box already, so I will get to those. Other things I hope we might get to talk about in the question period will be the challenges of dealing with digital things like this app / website stuff that you just alluded to. But so I'll start with the ones in the question box at the moment. So from Eldon Spackman, who's I think associate professor at the University of Calgary. So why must you show cost savings for NICE, I guess?
Yeah, I'm not entirely sure of the history of it. So the MTEP, the Medical Technology Evaluation Program, was set up as a way to support medical technologies in getting a kind of quicker and easier appraisal. So I guess historically a lot of the technologies that would go to the MTEP process were kind of technologies that just kind of weren't that invasive, didn't necessarily have a huge impact on patient outcomes, but maybe made things more efficient. So I'm not entirely sure of the history of it, but essentially there would be, as I understand it, there would be an option for Sleepio to be evaluated on the basis of a cost utility analysis, but there's very little. There's one study from which we can map some quality values for the effect of Sleepio, and it seems to be effective, but there's not robust evidence in terms of utility. So yeah, so that was kind of where we were left. It was the need to demonstrate cost savings.
Okay, thanks. So the next question again is another one from Eldon. So given the nature of the technology, the digital nature of the technology, is there a way that you can collect health-related quality of life through the technology or through the interface?
Yeah, that's a really good point, and something that I hope I get the opportunity to work on with Sleepio, and I guess perhaps in other contexts. So the standard data collection for Sleepio is already reasonably good. So they do collect some outcomes. So I think there's PHQ and maybe GAD of some sort. So it collects some kind of generic mental health type outcomes, which could be mapped to generic preference-based measures that we might be interested in. And of course, it collects sleep-specific outcomes as well. But yeah, there certainly is opportunity for that, and especially when we tend to work with quite short questionnaires, which are quite straightforward. Adding those in seems to me entirely feasible. The problem is that you don't get any kind of comparison from that data from users. You only see changes in quality of life for people who have decided to use Sleepio in this example. So it still leaves the question unanswered of treatment effects in those terms. But nevertheless, I think it would, it would be a valuable development, I think, for them.
Okay. So the next question, sorry, I'm just trying to find the next question here. Thanks for that. And so I think Eldon's final question is, can you speak a little bit more about why the current HTA processes aren't really set up for evaluating this type of technology?
Yeah, so I'm not sure what the answer is to that, but I think, and I'm speaking here from very limited experience of being part of NICE processes, so I don't think my experience should be assumed to be representative, but I think that the process is still very much built on the traditional clinical trial comparative analysis, which is able to identify the effects at the individual level. And I think for this type of technology, that becomes difficult because a lot of digital technologies are just kind of released into the wild, and all of the kind of dynamics of selection that take place in the wild need to be taken into account. So I'm not sure of the extent to which a clinical trial is the best way of, particularly in the context of resource use, I'm not sure that a clinical trial is the best way of doing it. And I think that NICE and I guess probably other agencies and other kind of decision makers in healthcare are still very much geared towards the clinical trial and that identifying treatment effects in that way. And I think we see that not just in appraisal processes, but I think from NICE we also see it in other types of guidance. Everything is geared towards the requirement of clinical trials. Where we see NICE talking about evidence standards, it's usually focusing on trials.
Great, thanks. That's something we're facing here increasingly as well. So challenging area. Chris McCabe is added to the comments about the MTAC. Just to say he was on that. He was an original MTAC member.
All right.
So and he was, if I understand correctly, it was meant to expedite the technology access and was thought of as a lower evidentiary hurdle. So it was set up in that context. But
yeah.
So. But he did also have a question, Chris McCabe, that is about external environment and whether any changes in the external environment might have impacted the magnitude of effect. And he's thinking particularly about Brexit in the time period of your
Yeah.
analysis, and whether that's something you've controlled for or thought about.
I mean, it says a lot about my bubble that I didn't even consider Brexit until quite a while after we finished doing most of the analysis. It hadn't even occurred to me. I'd spent some time thinking about what might be important during the time period that might have affected things, and yeah, I think so. I think Brexit is the main one. It's the only one that anyone else has mentioned to me. So I'm glad that Chris has mentioned it as well. But no, the short answer is no. I've spent no time as yet thinking about what the impacts of that might be. We are seeing some research come out around the impacts of Brexit, so I should probably dig into that and see whether it might affect our results one way or another. But yeah, I'm open to any other suggestions beyond Brexit as well.
Okay, thanks. So the next question is from Dat Tran. Dat is one of the health economists here at IHE. So how did you decide how to include certain covariates in the model? So for example, the age bands or gender or sex and things. Did you have a test to decide whether or not to include them, or was it some other approach?
So essentially, we've had very few things that we could include as covariates. So the model included everything that we had in the first instance. And then when we tested the alternative specifications, the only real test I did was just plotting the predictions, and in the main model, all of the covariates were significant predictors. But beyond that, no, it was simply a matter of just including everything that we had, which was included in the data set because we thought it would be important. But no, we didn't spend. It's a while since I did it, but I don't think I did any specific tests on any kind of information criterion tests. So I may have done.
Okay.
Which is maybe not a very satisfying answer.
Thank you. So another question from Dr. McCabe, which is, have you thought about any, have you or NICE thought about any distributional effects of an intervention that requires access to smartphone or internet?
Yeah, it's an interesting point. So I mean, NICE did a kind of equity impact analysis, but I think I suppose it's probably because there isn't really an alternative, that there wasn't. The process didn't seem to dwell that much on the issue of some people not having access to a computer. I mean, there was some consideration in the scope around people for whom the technology might not be appropriate, and so people with hearing problems, it's not necessarily appropriate for them. But the issue around people actually having access to computers, as far as I was exposed to it, it was quite a minimal part, of the evaluation process. And I suppose it would be important for Big Health to demonstrate that they're doing what they can to make it as accessible as possible. But beyond that, no, there was no formal evaluation of the equity implications in those terms, I don't think. But it is an important point and something that should be taken into account in future work.
Thanks. Yeah, I agree. It's an important point, and it's something that that I maybe hasn't been given enough consideration. There's a lot of I don't know. There's a lot of wishing for people to do online CBT in the UK as a regular thing because of the capacity constraint that you mentioned for in-person CBT, which tends to be restricted in my research and personal experience to those with the most severe mental health issues, and the solution seems that everybody can just do it online and do some self-guided learning, but that's not true of everybody.
That's right, and I think one of the perspectives was that CBT, face-to-face CBT is recommended for insomnia, but it's not provided. So in some senses, that is more exclusive than Sleepio. So if you were to make the comparison between Sleepio and face-to-face CBT, then arguably, Sleepio is more inclusive. More people can access Sleepio than can access face-to-face CBT. So in that respect, if you did do the evaluation, it might be quite favorable to Sleepio if the comparator is face-to-face CBT. But yeah, I mean, the issue remains that there are people who are digitally excluded and they need access to care.
Absolutely, yeah. So another follow-on from Chris is, does the incidence of insomnia have a socioeconomic gradient that you observed?
That's a good question. I don't know the answer to that.
I'd also be interested to know about incidence over the course of the pandemic period and how that might affect things. Anecdotally, I've heard a lot more about people not being able to sleep, and I've seen things in the newspapers and stuff. I don't know if it's well tracked.
That's a good point. I mean, there's certainly evidence around certain groups of people who are affected by insomnia, and people with non-standard work patterns, let's call them. People who work nights are much more likely to suffer from sleep problems, and I expect there's a socioeconomic gradient in that respect. But I'm not aware of a more general study that looks at socioeconomic gradient in sleep problems, but now I want to go and have a look.
Okay, thanks. So if there's any other if anybody else has any questions, please do enter them into the question box. I wondered, Chris, if you and at risk of asking you to repeat yourself a little bit, I guess, but to speak a little bit about the use of real-world data and real-world evidence for evaluations of this time and the challenges that you faced with those.
So I think when we got started, the fact that we initially thought about having some sort of randomized trial where different regions would be randomized to access or no access, and essentially we came to the conclusion that we couldn't recruit GPs from outside of the area, so it was a bit too difficult. But I don't think there's much reason to expect that would provide seriously different results. I don't think that I think the non-randomization aspect is perhaps secondary to the issue that we weren't able to observe exposure to Sleepio at the individual level, and that has been tricky with the appraisal. But in terms of identifying the overall impact of releasing a digital technology into the wild, it seems to me to be a very appropriate approach. Looking at how Sleepio impacts on the trend in average healthcare costs, it seems like the right question to ask. And I think, a lot of these companies, Sleepio is probably one of the best evidenced digital technologies that there is, at least of this kind. And yet, they still don't have capacity to be conducting big trials that collect lots of data. So being able to rely on data that is already collected by practices yeah, it's a much more feasible way of doing this research, and there's this could be extended beyond the data sets that we use. We would have quite liked to have been able to get some hospital data as well. We know that sleep problems are associated with accidents and things like that. So there are all sorts of potentials in terms of the real world evidence that could be used. But yeah, it seems to me that it's mostly untapped, this kind of methodology for the evaluation of digital technologies. We do see there's a few studies that kind of adopt this approach in the context of kind of public health type interventions. But yeah, in terms of evaluating digital technologies, I think it's underused. Underused.
Thanks. And so I think probably just the one last question is a follow-up from Chris on that about the data. Was it not possible, or do you think it would be possible in future to get consent to link Sleepio or other types of apps to NHS data at the individual patient level if consent could be done through the app?
Yeah, it's tricky. I mean, at the most basic level, you could ask somebody to enter their minimum identifiable details that you could then link to a data set. If you had someone's postcode and date of birth, then you'd be on your way and you'd be able to make the link. So in principle, I think it's fine. I think the nature of our study and the nature of the wider study within which we were embedded, the priority really was to not have to deal with identifiable data from GP practices. And of course, it's much easier in terms of ethical approval and in terms of getting GPs on board. It's much easier if you don't have to do those things, and you can work with a completely anonymized data set. But yeah, I think in principle it's possible, and had we been able to do that, I think the process with NICE would have been a lot easier in hindsight, but we hadn't really thought about that in advance. But yeah, linking NHS data to data that is collected through a entirely separate app seems totally feasible to me. Yeah, I suppose the only barrier is the ethical approval, really, and making sure that people opt in,
and getting the NHS to actually release the data. But that's for a different session. So we are now just right up at 1 o'clock. So I want to just take a second to thank you, Chris, for your presentation and for answering the questions. Unfortunately, we can't give you a round of applause properly, but please accept our thanks and our show of appreciation for doing this. Everyone else, thank you, everyone who's attended. Our next rounds will be taking place on May 19th. And we will be hearing from Dr. Hugh Lloyd-Ellis of Queen's University in Ontario, who's going to talk about quantifying the economic impact of COVID-19 policy responses on Canada's provinces in almost real time. And if you go to the NOAA website, you can register for that. And you'll hopefully got some reminders as well through emails for that. So please do register. But once again, thank you, Chris. And thank you everyone for attending. Thank you. Bye-bye.